Good evening, everybody, and welcome to the second daily Maverick webinar of 2021 on the issue of the development of vaccines for COVID-19 and their use in South Africa. Thank you for joining us this evening. Thank you for your interest. We have a record 2,800 people registered for this evening, and we received, I think, 70 or 80 different questions before the webinar. And I have to say at the outset that it would be very difficult to answer every question. So please see this as part of an ongoing conversation. Our last webinar was nearly a month ago. In that month, a great deal has happened, and particularly in the last 48 hours. Since, I think, Saturday night, when we heard news around the AstraZeneca vaccine. There's been a lot happening, and it has created a lot of interest, a lot of anxiety, a lot of confusion. So I think, again, we're very, very lucky this evening to bring back two of South Africa's foremost experts in vaccines and two people who are on the front line of vaccine trials. First of all, to introduce Professor Shabir Madhi, the Dean of the Faculty of Health Sciences at Wits University, and a vaccinologist and principal investigator in several trials. Thank you for joining us again, Professor Madhi.
Thank you, Mark.
Thank you. And secondly, to welcome back again Professor Glenda Gray, the president of the Medical Research Council, also a principal investigator in the Johnson & Johnson vaccine trial, another person who's intimately involved in advising government and advising all of us on this issue of vaccine development and how we can roll out a successful vaccine program in South Africa. So, Glenda and Shabir, I'm not going to give you lengthy introductions tonight because time is short and interest is great and there are many questions. Shabir, I want to start just by asking you to step back a little bit from the fray, as it were, and tell us just where exactly are we in the world with progress in the development of vaccines for COVID-19. Is the arrow pointing in a promising direction, or is it promising in a worrying direction? And in particular, will you comment on the development of vaccines that meet those two critical criteria of vaccines that are, first of all, safe, and secondly, vaccines that are efficacious, that work, that are going to work and help us to overcome the COVID-19 epidemic? So, Professor Madhi, if you could just start this evening's conversation. Thank you.
So thanks, Mark. So, Mark, I think we're sort of heading towards the first anniversary of the first case of COVID-19 having been documented in South Africa. And around about March, April last year, when scientists were saying they will have a vaccine available within a 12 to 18-month period, I myself was skeptical that was going to happen, because usually the minimum period it takes, the average period, takes about 10 years to get a vaccine developed. Yet 12 months, 13 months into the pandemic, we now have got not one, but we've got 7 vaccines that have been authorized for use by at least one regulatory authority. And these vaccines use different sort of technologies. And for the best part, all of these vaccines, at least against the original virus that was circulating in the world, have been highly efficacious. The minimum efficacy has been perhaps for one of the Chinese vaccines, which is an inactivated vaccine, very different from the technology that's used for the other vaccines. But even that one met the minimum threshold which the regulatory authorities set in terms of what they expected of a vaccine. And that was efficacy of more than 50%, which means it reduces your risk of developing disease by at least 50%. For many of the other vaccines, the efficacy has been north of the 50%, for some up to 95%. So there's been phenomenal success in terms of the development of what I would call the first generation of COVID-19 vaccines. They've been highly efficacious in preventing illness due to original virus that was circulating. And in fact, for many of these vaccines, they're much more efficacious, or they got a higher point efficacy estimate against severe disease than against all severity illness. And I think that is important. So to some extent, until very recently, I would say that we've been in a honeymoon period when it comes to COVID-19 vaccines. Nothing was going wrong. All of the ducks were just aligning in a row. The readouts were much better than what we expected. And for all of these vaccines, many of the ones that have been authorized, they've been evaluated in 30, 40,000 individuals. And foremost of concern when it comes to deployment of any vaccine, not just a COVID-19 vaccine, is establishing its safety. And for all of these vaccines that have been authorized for use now, including the Sputnik 5 recently, I think the safety tick box has been checked now. So these vaccines are safe. These vaccines are efficacious against the original virus that was circulating, irrespective of severity of illness, and in fact, much more efficacious probably against severe disease. And the reason for that probably is that you require different sort of, the vaccine induces different sort of immune responses. There are two major arms, what we call antibody responses and T lymphocyte responses. And depending on how successful the vaccines are in inducing those, stimulating those responses, will determine just how well the vaccines would work in protecting the full spectrum of disease from mild to severe.
Okay. And just before I move to Professor Gray, I mean, you've talked about a honeymoon period. You talk almost as if it's miraculous that in a very, very short period of time. I know some people are worried that to be able to develop 7 new vaccines against the virus that has now caused so much death and destruction across the world must have involved shortcuts of some sort. They're worried about safety, about is this really the case? Can you just give us a sense about what was the kind of starting point for the development of these vaccines that has made possible this progress that you have described?
Yeah. So in addition to the 7 that are authorized for use, there's another 35 that are in human trials, in late-stage human trials. And what has allowed for us to be successful is that essentially much of the scientific community has basically diverted their attention away from what they previously focused on, as an example, HIV and TB, and they've basically redirected their attention to development of COVID-19 vaccines and understanding this virus. In addition to which, for many of these vaccines, is actually piggybacked on technology that was already established to develop vaccines for other purposes, as well as technology that was developed to actually treat cancer using a vaccine type of an approach. So it was basically tweaking the technology that was already existent, that had been developed for other vaccines as well as for other reasons, and deploying that. Now, what also happened with COVID-19 vaccines is often these clinical trials, what we call phase 1, phase 2, phase 3, they take place in series. But because of the huge effort that's gone into it and amount of funding that was available, companies were willing to take a risk. And they started their phase 2 studies pretty much before they had a phase 1 study readout, and similarly for the phase 3. So we've had parallel streams of studies taking place with the same vaccine, which usually wouldn't be the case. Usually you would have a pause between your phase 1 and phase 2, another pause between phase 2 and phase 3, and that extends the timelines. So there haven't been any shortcuts when it comes to the safety of the vaccine. Obviously, there are questions about long-term safety, but most of the safety issues when it comes to vaccines are issues that materialize in an immediate period after you're vaccinated.
Thank you. I think that's very important to understand. Professor Glenda Gray, would you like to add anything to that? And can you also, Glenda, give us a sense of what number of vaccines are actually now in use around the world? Because I think, last time we had this discussion, it was a theoretical question in many ways, but things have moved fast in this last development. So your view, please, on how things have progressed or not.
So I think we've made a huge progression in terms of rolling out vaccination at a global level. And I think there's great success. So we've heard about the success of Israel, who's vaccinated more people per 100,000 population than any other country, and are showing impact on both efficacy after the first dose and as well as impact on COVID cases. So I think that's been very exciting. So millions of doses are being rolled out as we speak in many parts of the world. And so I think that's important. I want to just make the point about the the accelerated development, and my dogs are going mad at the background, so maybe I'm going to just quickly say something and then go and sort them out. But essentially, there's a hardy dog flying around, so they're getting excited. But essentially, I wanted to also make the point about the huge injection of public money, of federal funds. The reason why we've also been able to accelerate vaccine development is because governments have also put money into product development and have de-risked the vaccine development, which has enabled the manufacturers to race ahead to accelerate development at risk, because they were supported by huge amounts of federal and public funding. So that's important. So public funding is essential in times of pandemic. But what we do see is the rollout of vaccines in all parts of the world. And what we also do see is the concomitant controversies around the rollout. We see the debates about age, about efficacy, and we see the debates about vaccine hesitancy and people who are worried and don't trust the program because of the rapid acceleration to roll out and the dash to make an impact. So I think that we're in an incredibly important phase. I think what we are learning with the emergence of the variants is that we need to look at the impact of the variants on the vaccines that are already developed. You know, these vaccines were developed against the wild type Wuhan strain, which was what I would call vanilla COVID. And then with the evolution of the various variants through whether it's Brazil, South Africa, or the UK, we started to see an impact of the variants on vaccine efficacy, and makes one have to recalibrate and to also look at what are the second generations of vaccines coming forward. But that doesn't mean that the current boutique or portfolio of vaccines should not be rolled out or should not be evaluated in populations where they've been found to be efficacious.
Thanks, Glenda. Just to point out to people, you'll see at the top of the chat box that we've developed a bit of a glossary this time for some of the terms that are commonly used. You can download it, but you'll see it says variant, a version of a virus after it has mutated. And Glenda and Shabir, I want to come back to this question of variants, because it's a game changer in some ways. But before we go to variants, again, just in terms of laying the foundation for this discussion, Shabir, first of all, can you just tell, because this is a question that was asked by many people before this evening, what does the vaccine do? I hear people talking about vaccines that prevent infection. I hear people talking about vaccines that prevent or don't prevent mild to moderate COVID-19. I hear about vaccines that prevent or don't prevent severe infection, hospitalization, and eventually death. Can you simply just explain why you make that distinction and how important it is?
So, Mark, the immediate priority is to be able to prevent people from dying and to protect our healthcare services, so prevent people from being hospitalized. And that obviously represents the one extreme of COVID-19. But to be able to get on top of the pandemic and to be able to sort of minimize the chances of us experiencing multiple resurgences, as well as to reduce the magnitude of those resurgences, what we want on the other end of the spectrum is for vaccines to make people less infectious, which basically means that if they are exposed to the virus, even if they become infected, the immunity that's induced by the vaccines will prevent them or reduce the chances of them transmitting the virus onward. So that is the two ends of the spectrum. Now, the ideal is to have the vaccine that reduces infectiousness, and for all intents and purposes, any vaccine that succeeds in terms of reducing infectiousness certainly will prevent severe disease. But in between that, you've got this gray area in terms of mild illness and moderate infection. As we know with SARS-CoV-2, with COVID-19, roughly about 40 to 60% of people that are infected with the virus would be completely asymptomatic, but they still could contribute to others being infected. So that's the reason why we're wanting to reduce infectiousness. When we talk of a mild illness, what we're referring to is an upper respiratory tract infection. So your congested nose, your sore throat as an example, that is your upper respiratory tract infection. And that sort of represents a self-limiting illness, which is a mild end of the spectrum. and the moderate would be somewhere between the two, where we got some lung involvement, depending on the definitions that they use. So this is your full spectrum. Now, the immediate priority is prevention of severe disease and death. The ideal vaccine is one that's going to reduce infectiousness as well as prevent mild infection, and that is a spectrum. So hopefully that clarifies some of those concepts and why we're wanting vaccines to work for both ends of the spectrum, but again, to emphasize the priority is saving lives in the immediate future.
So
correct me, Glenda, yes.
So just to further what Shabir said, so the vaccines that we have individual health benefits, and they also have public health benefits, and they have economic benefits. So the individual health benefit is that the vaccines that we have stop hospitalization and death, and that's an important individual benefit for a vaccination. The public health benefit that vaccinations have is that by preventing hospitalization and death, you resuscitate your health system and help the country get on with its business of providing the healthcare to people who need it. And the third thing about vaccines is they have economic benefits. They protect teachers so that we can keep the schools open, and they allow workers to go back to work and keep the economy going. And so maybe we shouldn't think about do these vaccines help with transmission or this and that, but think of it in the spectrum of how vaccines allow us to get on with our daily business of keeping our society open and keeping our schools open, keeping our hospitals free of and also helping our families not suffer from death, the devastating deaths that we've had in our country. And so I think we've got a lot to celebrate, because imagine vaccines that stop death and hospitalization. Isn't that what we're looking for in a vaccine?
Thank you. And so again, I'm just stressing this because viewers have asked this question. A vaccine doesn't necessarily prevent you from being infected. The critical question is, does it prepare your immune system effectively to respond to prevent illness once you've been infected? Is that how people should be looking at it?
Exactly. I mean, if you're exposed to someone that's transmitting the virus and you're in close contact with that person, you will become infected. The question is, how well does the infection establish itself in that individual that's been exposed? And what vaccines are wanting to do, or what you're wanting to achieve with vaccines, is to sort of attenuate the clinical cause of that infection and for the virus to get rid of the virus as quickly as possible. So you're still infected, but it doesn't mean that you're going to become symptomatic, or you'll be less likely to become symptomatic if the vaccine is able to work quickly enough and well enough in preventing a mild infection. But again, it's about the severe disease and the death that we need to focus on now.
Okay. Now, I'm going to come before long to practical rollout questions in South Africa. But Glenda, I saw a question from somebody, Graham Leslie. What's the history of efficacy of vaccine mixes in suppressing viral diseases? Is there a history? Have we been successful with vaccines in viral diseases before?
With Ebola, Zika, RSV, measles, smallpox, rubella, polio. Shabir, help me out. What one have I missed? So those are
the answer is
hepatitis B, HPV. The list is endless. I mean, so HPV for cervical cancer. And measles, and then let's start talking about the bacteria pathogens that have protected children from pneumococcal pneumonia and Haemophilus influenza. So there is no doubt that these vaccines have impacted and allowed our children to survive and allowed us to control or eradicate pathogens from the face of the earth.
So the history has been successful. And as we see,
I think that's really successful. It's increased infant mortality, under 5 mortality. It's eradicated and managed smallpox and a devastating disease like polio. We don't have iron lungs and deformities and paralysis because of a vaccine. That's profound.
Great. So as we sit here, we have 7 vaccines that have proven safety now, proven efficacy Shabir said we have 35 in the pipeline at least. Urgency and the toll that COVID-19 is taking on our globe and our societies explains the rapidity with which we have risen, the scientists have risen to meet this challenge. But then we met another challenge, and I want just 5 minutes on this because it brings us to this week. We started developing vaccines in relation to what Glenda called the vanilla type or the wild type virus, the original virus. Since November last year, we've heard about mutations in South Africa and Britain, in other places. Does that change the game? Are we going to have to be constantly adapting vaccines to a mutating virus? And does that change perspectives? But before you answer that particular part of the question, will you also say, what is it that is making this virus mutate? And does it have anything to do with my behavior, whether I wear a mask, for example, or how prone I make myself to being infected or infecting somebody else? Can we try and get to the bottom of this viral variant issue? And the last question I'd ask both of you on this is, when do the mutations depart so far from the original virus, the wild type, that as you call it, to become a new strain altogether? Shabir, would you like to kick off on that front?
Yeah, so Mark, answering that question in 5 minutes, it's going to be a challenge.
Okay, sorry.
I will try. So I think, I think those are really important issues, both in terms of why the current variants evolved, as well as in relation to what its implications are for vaccines moving forward. So why did this mutation evolve in South Africa, and why did a mutation evolve in Brazil, in Manaus? These are two settings that are examples where there was a tremendous force of infection the first time around with the first wave. In South Africa, roughly about 30% of adults were actually infected during the course of the first wave, based on early serosurveys as well as more recently conducted serosurveys that have been concluded. So 30% of individuals developed some sort of immunity, and those individuals had these antibodies that have been circulating around. Now, the same individuals are going to be exposed to the virus, and when the virus comes across those antibodies, it's under attack. And the only way for the virus to survive, essentially, is to try to evade those antibodies. So what does the virus do? It mutates. And it mutates specifically in those regions which the antibody is targeting to destroy the virus. So the evolution of these variants, these mutations which involve critical components of what the vaccines are targeting at the moment, is a consequence of the virus being put under tremendous pressure over a protracted period of time. And I think that's also important. So when it comes to vaccines, the reality is that we're probably going to face the same scenario, especially when there's a sluggish rollout of vaccines. So if a small percentage of the population are vaccinated and develop this sort of antibodies, what ends up happening is that the virus continues transmitting, becomes exposed to these antibodies, and simply continues mutating to try to evade that antibody that's been targeted at it. But there's another part to the story. So the evolution of these mutations is a consequence of, part of it is just error in terms of the reading of the genetic material when the virus is replicating. But the key components that are mutated, that are becoming resistant to the antibody that was induced by past infection, is a consequence of the force of these viruses trying to evade the immune responses, specifically the antibody responses that's been induced against it. Then there's another part of this, T-cell immunity, which is sort of a different component. And it's important to also understand that, because when it comes to preventing COVID-19, preventing severe disease might be more dependent on the T-cell immunity rather than these antibodies that are circulating. And fortunately, when it comes to the T-cell responses to vaccination as well as to the virus, those responses are relatively spared. Some of it, there is some fallout in terms of the T-cell responses, but they're relatively spared in terms of still being able to tackle the virus if a person is infected. And that might have implications for vaccines that might not necessarily protect against mild infection, but could still protect against severe disease.
Thank you, Shabir. And I'm going to ask Glenda to, in your answer now, to also help us, because Shabir talks about T-cell responses. Can you also simply explain the difference between the antibody response, because as I'm understanding it, there's almost two phases, the antibody response and the T-cell response. Will you help us understand that Glenda, as well, in your response on this question?
So let me have a go at it. So you get vaccinated, and within days after being vaccinated, two things happen. You get an increase in neutralizing antibodies that usually peak around day 28 after vaccination, or you get and you get an increase in what we call binding antibodies. So both binding antibodies and neutralizing antibodies increase over time after vaccination. And these two arms of the humoral immune system are very important. They either neutralize the virus, the neutralizing antibodies, or they bind to the antibody. I mean, they bind to the virus so that they render the virus inactive. And also these antibodies also generate antiviral properties that also work against the virus, as well as activate a whole lot of non-neutralizing and other kind of responses like interferon cytokines, all kinds of little things. So if you can imagine, there's an enemy, and you have your guys with the guns, the guys with the spears, the guys with the tornadoes and bazookas, and those are the antibody response. And then you've got people throwing sticks and rocks, and those are your antiviral responses. But everybody is involved in a war with the virus, and it's the big guys and also the small guys at the back. But also, and while all this is happening, you have an induction of another part of your immune system, which we call your CD4 helper cell response, and also CD8 responses. And all of these are just components of the immune response that is set to help you fight the virus. Usually what happens after the infection goes away, everyone goes to sleep, and you have your CD4 memory cells, which can be long-lived. So if you ever get exposed to this pathogen again, it wakes up the whole army and responds again. And so that's kind of the basis of which, more or less, there's obviously other factors. I'm simplifying it, and I'm not an immunologist, but I'm simplifying it as much as possible. But that's basically what happens. And so if a virus knocks out one part of the immune system, like neutralizing antibodies, we also want to know what else did that mutation do to the immune system. So it took your arm off, did it take your leg off, and did it take your ear off? So how badly did it impact on your ability to fight the virus? And so we have to investigate that, and that's exactly what happened in South Africa. And Shabir can tell you that further, is that once we found that there was this variant, the next question that we had to ask was, what does it do to vaccines, and what does it do to normal disease and infections, and how does it transmit? And so those are all the questions that we have to ask when we see the emergence of a new variant. And the scientists in South Africa have been working incredibly hard since the variant was discovered. We rapidly put together teams who are working on surveillance, on genetic analysis, on gene sequencing, on looking at the burden of disease in people, and also, very importantly, what do these variants do to our vaccine efficacy? And I guess that's where I'll hand over to Shabir, because I think he's got the first part of the story to tell, both with Novavax and then with the AstraZeneca vaccine. And then I can talk about the Ad26.
Okay, so that's where we're going to go now. I just got a message from somebody, Noncledo from Equal Education, saying part 2 is the critical issue. What's happening in South Africa now, and where are we going in South Africa? Now, what's happening in South Africa was that a week ago, we received 1 million doses of the AstraZeneca vaccine. We were hoping to begin administering those to healthcare workers this week or the beginning of next week. And then we got the trial results, Professor Madhi, that showed that the AstraZeneca vaccine, whilst it had been efficacious on the wild type, is not preventing mild to moderate disease in the variant. And that brings us up to today and the discussion and the webinar that was hosted by the minister 2 days ago. So Shabir, will you take us from there, and will you take us to somebody called David White asks, if the emphasis is on preventing hospitalization and severe illness, why has the use of the AstraZeneca vaccine been stopped when it has only been shown not to work against mild to moderate illness, and the indications are it might be effective at reducing the severity of severe illnesses and hospitalizations? Should Professor Madhi's study on AstraZeneca at best be viewed as a pilot study with its small and non-representative sample? So over to you, Professor Madhi.
Yeah, excellent question. And I think a perfect prelude in terms of why we did a study in the first place. What was the study designed to address? What question was it designed to address, and what are the implications of the study? So we did what was called a phase 1B and 2A study. And that is basically trying to show safety of the vaccine, looking at immune responses, and as a proof of concept to see whether the vaccine is going to protect against COVID-19. We obviously couldn't second guess that there was going to be a variant that was going to arise at some distant time in the future. Now, the hypothesis that we were testing in the study was simple. We were testing a hypothesis as to whether vaccination of a certain demographic population, a population with certain demographic features, was basically able to protect against COVID-19 irrespective of severity of greater than 60%. If the vaccine efficacy was less than 60%, our study simply wouldn't be able to address it. So there was a specific hypothesis that we were testing, and we needed to accrue a certain number of cases before we could do an analysis to determine whether we could accept or reject our hypothesis of vaccine efficacy of at least 60% against all severity illness. So eventually, when we accrued an adequate number of cases to do that analysis, what ended up happening is that we obviously didn't meet the 60% threshold. And the majority of the cases ended up being mild. In fact, 2/3 of the cases were mild and 1/3 were moderate. So we can't pronounce using this data as to whether the AstraZeneca vaccine is going or not going to protect against severe disease. What we can say is that against the variant that's circulating in South Africa, this vaccine will not protect against mild infection in a younger age group, and certainly probably not in older individuals as well. Does the vaccine protect against severe disease? I believe that the vaccine does protect against severe disease. And I believe that there's a role for the AstraZeneca vaccine, not just in being rolled out in South Africa, but in other African countries as well. What is the basis for that? So the AstraZeneca vaccine is very similar to the J&J vaccine, which Glenda will speak about in terms of the technology that's been used to construct it. There are some slight differences in terms of the spike protein that is expressed by this, what we call vectors. But beyond that, the immune responses that's induced by these two vaccines are almost identical in terms of that neutralizing antibody that Glenda was referring to. In addition to which, both of these vaccines induce what we call the T lymphocyte responses, both CD4 as well as CD8 responses. Now, what happened in South Africa is we've got a readout against a certain spectrum of disease, which is mild illness, and certainly I wouldn't be advocating this vaccine to be used in someone that is relatively well and healthy and that is not at risk of developing severe disease, because this vaccine is not going to confer any sort of benefit to that individual who's probably either going to have asymptomatic infection or mild illness if they are exposed to the virus. But for individuals with underlying risk factors for severe disease, for hospitalization and for death, there's a toss-up. And the toss-up is basically using a vaccine which very likely will protect against severe disease versus remaining unvaccinated into some distant time into the future when larger quantities of some other vaccine becomes available. And when I'm talking of another vaccine, I'm not talking of Sputnik 5, I'm not talking of Pfizer, I'm not talking of Moderna, because each of those vaccines need to be tested in terms of effectiveness against variant. The lab readout doesn't necessarily concur at this point in time in the absence of what we call a correlative protection, a minimum antibody concentration that could be accepted as indirect evidence of protection. That doesn't exist. So the only vaccines that we've got evidence for against the variant, firstly, is the AstraZeneca vaccine that doesn't protect against mild and moderate infection, the Johnson & Johnson vaccine that protects against severe disease and moderate to severe disease. And then we've got a Novavax vaccine. And the Novavax vaccine is a good example where the vaccine was evaluated in two different settings simultaneously, in South Africa and the United Kingdom. Now, the Novavax vaccine induces as good an immune response as any other vaccine that's been authorized for use. After the first dose, in fact, it induces a better immune response than the messenger RNA vaccines. With the same vaccine, we see an efficacy of about 60% in South Africa in people without HIV and 89% in the United Kingdom. And most of that illness, again, is mild and moderate illness. So the Novavax vaccine is far superior to the AstraZeneca vaccine in terms of preventing mild to moderate infection. But that doesn't mean the AstraZeneca vaccine is not going to protect against severe disease from the variant that's circulating in South Africa. The reason for the difference between South Africa and the United Kingdom for the Novavax vaccine is that the variant circulating in the United Kingdom is not resistant to this antibody that's been induced by vaccine or by natural infection. It doesn't have the same set of mutations, constellation of mutations that are present in the South African variant. So I don't think that we need to be halting the program, but what we can't do is go to healthcare workers and say all healthcare workers should be vaccinated, because it's not rational in that amongst the healthcare working force, 75% of the healthcare working force probably don't have risk factors and are not over the age which predisposes them to severe disease. So if you vaccinate all healthcare workers with an AstraZeneca vaccine, 75% of the healthcare force is not going to derive any benefit, because this vaccine doesn't protect against mild infection, which is what is going to result in them if they do become exposed to the variant. Whereas the other 25%, there's good reason, in absence of any other options which have been proven to work, there's good reason to vaccinate those other 25% with the J&J vaccine if it's available, if not with the AstraZeneca vaccine. And then the same thing applies to the other parts of the public workforce and everyone else. People that are at high risk of developing severe disease, right now there are two choices probably. Remain unvaccinated until the resurgence appears, or take your chances with a vaccine that is known to be safe and very likely protects against severe disease and death. And that includes the AstraZeneca vaccine.
So I'm going to move to Glenda, but you're saying you agree with the suspension of the rollout of the AstraZeneca vaccine at this point, but that it may still have, not may, it still does have uses, values in our context, particularly for people at higher risk. Just hold that. I want Glenda, because you were the principal investigator on the Johnson & Johnson trial, but I really want to get to practically what should we be doing now in this country, because we've got, many tens of thousands of healthcare workers who are daily exposing themselves to COVID-19 as they try to protect us and to protect people who are ill. Practically, what should we be doing, and on the basis of what understanding?
Okay, so I just want to finish off with the AstraZeneca study. Yeah. So I think it's important for the viewers to know is that there is a 30,000 strong vaccine trial evaluating AZ being conducted in the United States. And so why is this important? Because this study will give us information on severe disease and death and people with comorbidities. And so the trials that have been currently conducted with AstraZeneca have occurred in, not sick people and fairly young people. And so we need to answer the question about whether AstraZeneca works in hospitalization and death. And so hopefully this 30,000 strong trial that's been conducted to confirm all the findings in the UK and South Africa is being conducted at the moment. And so I think one thing I would suggest is that the study is fully enrolled and that we evaluate the vaccine going forward. So I think also it's important to note, that we do need further data on the AstraZeneca study because obviously as well there were issues around in low dose, high dose, low dose, standard dose, and we need to have a definitive readout, which the US study will help us with. So I think that I agree with Shabir that the AstraZeneca vaccine deserves further evaluation in a situation to see whether these vaccines in certain settings impact on disease and death. How that relates back to South Africa, we will need to be determined in the work. And what we do have at the moment, so I think that's very important, and these results will be out pretty soon. So I think We don't have to wait years to get those results, so that's important. The Ad26 vaccine is a single shot. So I think we also maybe just also need to remind the
Ad26 is Johnson & Johnson, yeah? Am I right?
The Ad26 J&J COVID vaccine is a single shot vaccine, okay, one dose, whereas the other regimens that have been evaluated at a global level are 2 doses. So this is like the first time we have information on a single shot dose. And why did we go ahead and do a single shot vaccine? We wanted to answer the question, can a single dose of a vaccine in an emergency situation impact or dent the epidemic? And so we wanted to ask that question. There is another study going on with Ad26 to answer the question about 2 shots. So we'll have answers. We have the answer of the 1 shot, and later on we'll have the answer of the 2 shots. So we'll be able to answer, can this vaccine work in an emergency? And if it can work in an emergency, what does it do? And then obviously the second trial that's been conducted is, do we need a second dose? And what does the second dose do? So all those are very important. But at this moment in time, we have a very strong, on the 29th of January, we heard from a 43,000 global study taking place in South Africa, Brazil, Latin America, and the United States that this vaccine impacted on death and hospitalization. There was, and it was impactful against the variant that we have in South Africa. The data is still being analyzed around asymptomatic and mildly symptomatic disease, and we'll be able to answer that question in the next couple of weeks. But more importantly, what we were asking for, like what can an emergency vaccine do? And an emergency vaccine can impact on moderate to severe and critical disease, including hospitalization and death. So this single shot emergency use vaccine can stop people from dying and people from going to hospital. It may not stop the sniffles, but if I could take a vaccine and not die or go to hospital, it's certainly the vaccine I would take. And I think it's important that the healthcare workers have borne the brunt of the epidemic. They've had to see terrible things. They've had to manage looking after HIV, COVID infection, and they've had to see their healthcare worker colleagues go to hospital and die, and they themselves have comorbidities and are at high risk of exposure. So this does represent an emergency use for a vaccine, in that it will help the individual and also will help the health system, because if this vaccine, if we show, as in the trials, that it impacts on death and hospitalization, we can start to manage the health system much better, and it'll have a better impact. And so you do want to send your foot soldiers, your healthcare workers, into the hospitals, into the clinics with a vaccine that's going to protect them from dying and going to hospital. And so I think the Ad26 vaccine shows that unequivocally, and it shows that in South Africa. And so I guess based on these new findings, these findings are 29th of January. They're 10 days old. So we have an efficacious vaccine in a highly powered study with very good confidence intervals, which gives everybody confidence to apply for emergency use authorization. And so emergency use authorization is occurred last week with the FDA. It's occurring in the next few days in the European region, and the J&J also submitted a rolling submission to SAHPRA to expedite the regulatory processes in South Africa. And so this Ad26 vaccine is being, as we speak, being processed for emergency use.
Do you know, because this will be on people's minds, how quickly can this J&J Ad26 vaccine be landed in South Africa and begin to be used? Because there's a sense of desperation, particularly amongst healthcare workers. Any ideas on that, Glenda? Do you know? So
obviously, when we saw the results and we saw the impact of the vaccine on vaccine efficacy, and we saw that that this vaccine could work in our country with our new variant, we started to have negotiations with J&J, and so the negotiations have been ongoing. I mean, obviously ongoing before that, but because these submissions were happening already in December. But so following those results, there were negotiations happening and discussions happening, and we have made advanced movement with the discussions enough to consider evaluating this vaccine in healthcare workers as we wait for the regulatory approvals to occur in all the regions. And so what we are discussing is whether under regulatory authorization we can use this vaccine rapidly in healthcare workers in South Africa as a single shot. We have the data. We are confident this is a vaccine that we know works. We know the safety profile, and we know it works in our region, and we know it works in our age groups in South Africa.
Thank you, Glenda. And I want to go back to Shabir now, and it's about this interrelationship between the the AstraZeneca and the J&J vaccine. There's a few questions coming through which are kind of on the same theme. If I take the AstraZeneca vaccine now, can I take a more effective vaccine in a few months' time when it's available? Can two different vaccines be used together, where AZ can be used and when the J&J available, use it? Somebody says, is Professor Gray saying we should throw away the vaccine that's sitting in Bloemfontein? Again, Shabir, quite practical questions about what we do now.
Yeah, so in terms of interchangeability of vaccines, those studies are currently underway in the UK, and hopefully we'll start those in South Africa as well. The bottom line is that there's no reason why, in fact, there might be some immunological benefit to having a different vaccine from what you received the first time around, especially when it comes to the non-replicating vector-based vaccines. So if someone receives an AZ vaccine or even a J&J vaccine now, and a few months later the Pfizer vaccine becomes available, because these vaccines are all pretty much targeting the same sort of antigen, the spike protein, it's just being presented in a different manner to the immune system, you probably would get a boost. And for some vaccines, you might get a better boost. So as an example, the Sputnik 5 is a good example where they got two different adenovirus. They got the adenovirus 26 and an adenovirus 5 vector, and they've got its prime boost. So that sort of heterologous approach actually might assist in terms of heightening the immune response in relation to the booster dose. So there's nothing that would prevent people. We don't have the hard data to support it, but from an immunological perspective, it's something that should work in theory and probably have some benefits to it. So getting the AZ vaccine or even the J&J vaccine right now doesn't necessarily preclude you from topping up, in a sense, with another vaccine that becomes available in the future.
Thank you. And you mentioned a couple of times, and again, people have asked about this, the Russian vaccine, the Sputnik vaccine. I don't hear it talked about as one of the candidates in our country. Is it a candidate? Is it as efficacious and safe as the other vaccines? And we also hear about the Sinopharm vaccine. I think that's the vaccine developed in China. Is that also something that should be in our basket at the moment?
Yeah, so the Sinopharm vaccine probably less so than Sputnik 5. And the reason for that, when they evaluated the Sinopharm vaccine, which is a complete different technology, is an inactivated vaccine, an inactivated virus vaccine in Brazil, the efficacy readout in absence of the variant that's currently the P1 variant, which is sort of this resistant variant, in the absence of that, the vaccine efficacy was 50%. So probably less effective than the other vaccines. For Sputnik 5, based on the article that was published last week, I think, in the Lancet, it indicates efficacy of 90%. But for all of these vaccines, it goes down to the same issue, that these are efficacy readouts against the original virus or original-like virus that was circulating. And if we do introduce any of these vaccines into South Africa, we would need to take a measured approach, in that we would need to introduce vaccines, test its effectiveness, especially against moderate and severe disease, before going at scale. And so it speaks to the other question that you asked earlier, and that is, do I agree with the suspension in terms of the rollout of the AZ vaccine? to healthcare workers? And the short answer is yes. Certainly as a block, it doesn't make sense to be vaccinating all of these healthcare workers with the AZ vaccine when a majority of them are not going to derive benefit. But for those that do have high risk and there's no other option available, those should still be vaccinated. So I think what's required in South Africa, we need to re-look the phased approach that we had in mind in terms of the rollout of the vaccine, and recalibrate in terms of what is it that we're trying to achieve with the current tools that we've got available to us. And what we're trying to achieve with the current tools that are available to us is not so-called getting to herd immunity. That is not going to materialize in South Africa and probably most other countries across the globe anytime soon with evolution of these sorts of mutations. What we're trying to achieve is a targeted approach in terms of protecting lives and preventing our healthcare facilities from being overburdened. So we need to become more selective in terms of who we target for vaccination, irrespective of whether they're healthcare workers, but certainly those healthcare workers still need to be prioritized.
So that's quite a departure, Professor Madhi, from the language that was being used by our government a week ago and by governments all over the world, that part of the objective is herd immunity. You're redefining the aim now. That's more, you say, more selective, more targeted approach to protect people most at risk. Glenda Gray, do you agree that we have to kind of reframe on the basis of emerging evidence and knowledge? Your sound, please. Sorry.
So I always view vaccination in a different way. So the first is, does the vaccination help the individual? And then does the vaccination have a public health benefit? And does the vaccination do anything else? And so I think it's important for us to understand that the current vaccines that we've evaluated have asked a certain question, that do these vaccines protect the individual? And we haven't done the transmission studies yet. And so we still need to do those. So the first thing when you do a vaccine program, you want to know if it works in the individual and there's benefit. And then once you know that, you then go on to different parts of the evaluation and, does this impact on transmission? And we do have evidence in rollouts that it does, like in Israel, where they have found a reduction in COVID cases based on their rollout. So we have some evidence, but we do need to do more transmission studies on the vaccines. So that's how I view a vaccination program. And so I think we don't know what is herd immunity with SARS-CoV-2. We don't know how much we need, and but what we do need is we need to know that everybody should get a vaccine that can protect them. And so I would like to think that the more we roll out, the more benefit we'll get, and that's what we're looking for. We're looking for benefit, and we're looking for control of the epidemic. And controlling the epidemic in the first phase is to stop death. Okay, we've had over 100,000 people dying in this epidemic. So if a vaccine stops 100,000 people dying, then that's the vaccine I want. We've almost run out of oxygen. We've had ICUs that have been full. We've been giving high-flow nasal oxygen in people in parking lots in the rain. And so if a vaccine can do that, it can stop, people having high-flow nasal oxygen in a car park in a hospital, then we're doing very well. And so if this vaccine does all of this, I think that it's important to roll out a vaccine that can help humankind by ameliorating death and dying and morbidity. So I think that's an important thing. You asked me about what we should do about the AstraZeneca rollout. I think we have to look around at the data that's happening. As I mentioned to you, there's a phase 3 trial occurring in the United States. It'll give us good information on the question that we can't ask in South Africa on mortality and hospitalization. So that's an important study, and we should wait for it. And then I also think that we should evaluate, we should look at other ways of evaluating AstraZeneca in a controlled fashion. And Shabir has mentioned some of the things like heterologous prime boost, using different primes, different boosts, and other designs of studies that could help us answer the question about the question that Shabir wants to answer, and that is, does this vaccine help against death and hospitalization? And that's an important question that we need to answer, but we haven't been able to answer just yet.
Thanks, Glenda. I see so many questions and I see 5 minutes left. And I have one major question to ask both of you before we finish. But there's a question, how long will it take for vaccines to be repurposed to deal with mutations? And is there a scenario where we get ahead of mutations? I don't know if you can answer that, Shabir, in 30 seconds. Somebody else hearing you talk about high risk and getting vaccines to high risk people said, what is high risk at the moment? And I think that bears repeating as well. Is it possible, Shabir, to deal with those two questions very fast?
It is. So I think we will get another generation of vaccines, including vaccines that are targeting the variant that's problematic in South Africa and Brazil. And those clinical trials probably will start in about 2 to 3 months from now. And depending on the regulatory requirements, those vaccines might well become available for immunization by the third quarter of this year. So it will be a much more expedited process if we can piggyback on looking at immune responses rather than needing to do large studies to look at efficacy. So the messenger RNA-based vaccines, as well as vector-based vaccines, as well as a protein-based vaccine by Novavax, all of those are being looked at to add an additional component that will be more specific to the B1351-like variant. So yes, I think that is on the horizon and in the near future. In terms of the high risk, we're looking at individuals over the age of 65, people with comorbidities such as hypertension, diabetes, obesity, and possibly the HIV group might actually well fall into that. Although with the HIV group, they've been less problematic in terms of severe disease relative to the other morbidities. So those, and then obviously there are the other chronic illnesses such as cancer, autoimmune diseases, and any other chronic disease that somehow interferes with your immune system would be considered sort of a high-risk group that needs to be targeted for vaccination.
Thank you. Thank you very much on that. Prof. Madhi, before I go back to Glenda and the last question for both of you, but what if by the time we have a vaccine that targets the 501 variant, there's another variant? Aren't we going to be chasing the tail of this vaccine, the tail of this virus forever?
So that's a problem with the current generation of vaccines, except for an inactivated vaccine that doesn't work too well. All of these vaccines are focused on a specific component of the virus, which is a spike protein. There are other vaccines that are currently in human trials now that is expanding the type of antigen that's being presented to the immune system. So in addition to the spike protein, there's another protein known as the N protein that's being included in these vaccines. And that will induce a different repertoire of immune response and might be less susceptible to this sort of mutations arising against which the vaccines won't work. So that would be a second generation of vaccine, which in a sense, that program is already started. And those trials are also in humans already.
Okay. So with 3 minutes to go, and I'll ask you this first, Glenda. We've covered a lot of ground today, but as you yourself pointed out, Glenda, this epidemic is raging. Well over 130,000, in fact, excess deaths since the start of the epidemic. 46,000 recorded deaths directly due to COVID-19. There's urgency about this, and both of you have called a vaccine a silver bullet, complementary to non-pharmaceutical interventions. On Thursday, President Ramaphosa gives the State of the Nation address. And I guess he's going to have to address this question. You are two scientists. You've made a whole bunch of recommendations as individual scientists. What would you hope, first you, Glenda, and then Shabir, that the president sketches out as the way forward with vaccines for South Africa following this weekend's news? Glenda first.
So obviously, I think he's going to have to tell us what he's going to do with the AZ vaccines and what the plans are to do with their use in South Africa. So I think obviously they obviously have to, the public needs to know what's going to happen to the doses that we have acquired. The president also knows that there are other vaccines that have been found to be efficacious. We heard Shabir's Novavax, and we've heard of the Ad26, and we do know that the mRNA vaccines that Shabir has spoken about are highly efficacious, and we've seen some in vitro work that there is a reduction in neutralization, but we don't know how much, so we have to evaluate that. And so the president does have a couple of other portfolios of vaccines that do show promise in this country, and I think that we would like to hear that there are advancements to bringing these vaccines into our country, and that we can start the vaccination program as soon as possible.
Thank you, Glenda. Professor Madhi, Shabir?
Yeah, so I think what the starting point needs to be, we need to recalibrate in terms of our thinking of the COVID-19 pandemic, how we respond to it, what the value of higher levels of restrictions are in terms of moving forward. And then we need to also, the president and the country needs to take its cue from the World Health Organization. And the World Health Organization came out yesterday and made it clear that they see still a major role for the AZ vaccine, irrespective of whether there are these variants that are circulating in Brazil or not. And that was after 5 hours of deliberation by the Scientific Advisory Group of Experts on Immunization at the World Health Organization, that they came up with that sort of, and there's a reason for that. I think if South Africa becomes reckless in terms of the manner in which we deal with the AZ vaccine, it's going to have global repercussions. And the reality of the situation is that the AZ vaccine is the cheapest vaccine that's going to be available to low middle income countries, and is going to be the most accessible vaccine that's going to be available to low middle income countries. I'm not saying that we need to get a second-hand vaccine for low income countries, but at the same time, again, the toss-up is going to be between no vaccine or a vaccine that has got a high likelihood of protecting against severe disease and death. So I think South Africa needs to be highly responsible in terms of how it approaches the AZ vaccine. Like I said, it needs to have a targeted approach in terms of who is targeted for vaccination. It needs to do appropriate studies to determine what the effectiveness is. There's not going to be any harm. There's no safety issue in terms of the rollout of the vaccine to high-risk groups. But we would be able to glean a huge amount of information in terms of how these vaccines work against severe disease in the context of where these variants are circulating, which has got global implications, and more so for the other African countries that will only have access to the AZ vaccine in any meaningful quantity.
Thank you very much, both to Professor Gray, Professor Madhi. I know that you are both very, very busy and will leave us now to go on and do other work this evening. And I promise not to keep you beyond 8 o'clock. I think that we've had a very rich discussion. I apologize to listeners that there are many, many questions that we couldn't answer. We could probably run this all night and still be dealing with questions. I'm also aware that there are critical questions around equality of access, around readiness for practical rollout, around making sure that nobody is left out as we begin this rollout, around the affordability of vaccines. And I promise you that we will address all of those questions as we proceed through this epidemic. I want to thank the 1,400 people who were still here a minute ago. And I want to just close by saying two things. First of all, I think we should thank all healthcare workers and acknowledge all healthcare workers again, who are still in our hospitals and clinics, who are exhausted, who are not supported enough, who are being exposed to and infected by, and in some instances dying of COVID-19. We need to show more support to those heroes and heroines who are keeping this country and keeping us together. So if any of you are with us tonight, thank you. And please pass on our thanks and our eternal gratitude. Thank you. And the second thing I want to say is just to everybody who is with us, which is we've got a long way to go through this epidemic still. Glenda said earlier on, we're trying to build a plane when we're in midair, and I think that's what this vaccine discussion is about. We may be through the second wave, but a third wave will come, particularly as we delay vaccine access. So we all have a responsibility to continue to protect ourselves, to take seriously messages about social distancing, about using masks, about protecting ourselves and protecting other people. So thank you, Glenda. Thank you, Shabir. Thank you, the Konrad Adenauer Stiftung Foundation. Thank you, my colleagues at the Daily Maverick who have helped put this together. And stay safe, everybody. And good night and good luck to all of you. Thank you. Bye-bye.